controls to reduce the transmission of tuberculosis. So what engineers can do and architects? High airflow, at least 6 room air changes per hour with an external exhaust. High efficiency particulate filters on the ventilation system. Ultraviolet germicidal irradiation. Negative pressure isolation. And personal respiratory protection like high efficiency particulate filter mask or respirator like N95 or N99. What is MDR-TB? A TB that is resistant to rifampicin plus isoniazid. And what is extensive drug resistant XDR-TB? It is resistant to rifampicin plus isoniazid plus fluoroquinolone plus 1 injectable. The most common extrapulmonary presentation of TB is cervical lymphadenitis. So if you see a cervical lymph node in a patient, think of TB. Next is pneumothorax. So there are primary and secondary pneumothorax. Primary pneumothorax occur in a structurally normal lung, healthy lung, and secondary occurs in a diseased lung. So primary can be spontaneous and traumatic. Its risk factors are male, Marfan syndrome, change in atmospheric pressure, physical activity. Traumatic pneumothorax, as you know, can occur due to trauma, iatrogenic or non-iatrogenic. What are the causes of secondary pneumothorax? These are airway disease, interstitial lung disease, infection, connective tissue disorder, cancer, catamenial pneumothorax, which is due to thoracic men's endometriosis. Wow. Thoracic endometriosis, catamenial pneumothorax. Tension pneumothorax develops as inhaled air accumulates in the pleural space, but it cannot exit due to one-way valve system. When intrathoracic pressure rises to more than 15 to 20 millimeters of mercury, the venous return and the cardiac and lung function are severely restricted, resulting in hypoxemia and shock. In critically ill patients who cannot move to an erect position, look for deep sulcal sign as seen here, a profound lateral costophrenic angle on the affected site. Here you can see the normal seashore, and this is the normal seashore, and this is the barcode appearance, and you can see a secondary spontaneous pneumothorax developing in a patient in a diseased lung. What is the criteria for stable patient in a pneumothorax? Respiratory rate less than 24, no dyspnea, speaks in full sentence, pulse is more than 60 and less than 120, normal BP, normal saturation in new room air, and no hemothorax. Do aspiration and tube thoracostomy. The devices we use, if you use a single aspiration, insert a needle or catheter, aspiration of air using an attached syringe, and immediate removal of the device. This is single aspiration. Then there is needle aspiration. Use 18 gauge needle, and you can place a small size catheter less than 14 French, small size chest tube 10 to 14 French, pigtail of a 14 French using Seldinger technique, a moderate size chest tube of 16 to 22 French, and a large tube of 24 to 36 French. What is the treatment of pneumothorax? If it is a small primary pneumothorax, observe for 3 hours, repeat chest x-ray. If there is no symptom and the pneumothorax does not increase in size, return to evaluation. You can insert a small size catheter and aspirate, followed by immediate catheter removal, then observe for more than 3 hours. discharge if no symptoms occur, or a small size catheter aspiration or small size chest tube can be inserted. In small secondary pneumothorax, you need to insert a small size catheter or small chest tube. In large pneumothorax, a moderate size chest tube and admission is required. In a tension pneumo, immediate needle decompression followed by moderate or large size chest tube is required. And you need to use a large size if fluid or hemothorax is present. Air transport with pneumothorax. Increased elevation causes an increase in gas volume, so increasing the risk of tension pneumothorax at air transport, particularly when transported in a fixed wing vehicles. Do not fly 7 to 14 days after a pneumothorax resolution. And about diving, current guidelines suggest that a history of spontaneous pneumothorax is a contraindication to underwater diving for the lifetime unless you have undergone surgical pneumothorax and normal lung function exists. So once you have a pneumothorax, you cannot dive at all, scuba dive, but if you have undergone surgical pneumothorax, you can dive. Now coming to asthma. What will happen is asthma is there is increased airway resistance and there is expiratory limitation. So the expiratory flow is less, causing air trapping, increased airway pressure called as autopeep. This pressure leads to barotrauma, and this increased pressure will reduce the venous filling of the heart, causing adverse hemodynamic effects. There will be VQ mismatch because वेंटिलेशन ठीक से नहीं हो पा रहा, एयर ट्रैपिंग हो रही है. दे विल बी हाइपोक्सीमिया, हाइपरकार्बिया, इंक्रीज वर्क ऑफ ब्रीदिंग. दे विल बी पल्सेस पैराडॉक्सिस and respiratory muscle fatigue will occur. What is pulsus paradoxical? Normally systolic BP falls during inspiration, but there is in pulsus paradoxis there is exaggerated fall in SBP during inspiration more than 10 mmHg. So paradoxis is more than 10 mmHg. Paradoxis is more than 10 mmHg fall in SBP during inspiration. It is seen in asthma. How do you classify asthma? It is mild, moderate, severe and life-threatening. Mild is peak expiratory flow more than 70%. PEFR 70, 40 to 69, less than 40 and less than 25. So mild, moderate, severe, life-threatening, PEFR 70, 40 to 69, less than 40 and less than 25. What are asthma mimickers? All the causes that can cause dyspnea, like heart failure, upper airway obstruction, pulmonary embolism, foreign body aspiration, tumors, interstitial lung disease, vocal cord dysfunction, etc. So how will you treat asthma? First is initial assessment. You will take history, physical examination and auscultate the patient, see the use of accessory muscles, his vitals, peak expiratory flow rate and FEV1, SpO2 and other tests. So if we will decide based upon the PEFR. If the FEV1 or PEFR is more than 40%, it is mild to moderate. If it is 25 to 40, it is severe. And if it is less than 25, it is life-threatening. So if the patient is severe, you are going to intubate and mechanically ventilate the patient. Nebulize salbutamol and ipratropium, IV steroid, magnesium sulfate, and see treatment under status asthmaticus, admit to the ICU. If the PEFR is 25 to 30%, you will provide oxygen, nebulize with bronchodilator, salbutamol and MDI, ipratropium every 20 minutes back to back for at least 1 hour. And oral systemic corticosteroids are provided. If it is mild to moderate, oxygen, SABA, nebulize MDI and systemic corticosteroid. We will repeat the assessment and we will see whether the patient's PEFR has improved with our interventions or not. If the patient's peak expiratory flow is still less than 40% predicted, we will again repeat our measures. If the patient still has poor response, we will admit to the ICU, start adjunct therapies and assess the patient for need of possible intubation. If the patient does not improve, does not need intubation, we will admit in HDU and oxygen inhaled SABA will be provided, systemic steroid, and consider the adjunct therapies. If the patient improves, we will discharge home.